Hey everyone, welcome back to my channel. So this video will be looking at schizophrenia, which is part of the paper 3 of AQA A-level psychology. And I know a lot of people are asking on the comments and videos, but this should cover everything that you need for the exam, because I didn't have my revisions notes for this, so I followed a CGP textbook, and I believe that should have everything in it that you need to know. So yeah, let's just jump straight into it, and obviously give this video a like and subscribe, and feel free to comment down below any questions you have, or just give support to other exam takers. So firstly, looking at the classification of schizophrenia. So schizophrenia disrupts the mind's ability to function, impacting a person's perceptions, emotions and beliefs. Males tend to develop it during their late teens to early 20s, whereas women develop it during their mid-20s. The DSM classifies all mental disorders, stating that those with schizophrenia should show at least 2 of delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, or any negative symptoms. Cultural bias. There is cultural bias when diagnosing, as Copeland et al. In 1971 found 69% of American psychiatrists diagnosed a particular patient, but only 2% of British doctors diagnosed the same individual. And obviously there can be possible symptom overlap. So positive symptoms include hallucinations, delusions, jumbled speech, and disorganized behavior. Obviously these aren't good symptoms to have, but by positive it means that adding something to the individual rather than taking something away. And then negative symptoms is speech poverty, lack of emotion, avolition, which is basically disinterest in activities, and a lack of ability to function normally. So if you see the difference, positive symptoms add something to the person, even if it's not necessarily adding a good thing, whereas negative symptoms take something away. So here are a few biological explanations. So firstly, genetics. So being genetically related can increase chances of developing schizophrenia. I think, for example, my uncle is actually schizophrenic, and I believe I have about 10% chance of getting schizophrenia. Gottesman 1991 reviewed 40 twin studies and found identical MZ twins had a 48% concordance rate, but this was only 17% for DZ twins. Shields in 1962 found MZ twins raised in different families still showed around 50% concordance, but obviously no study has found 100% concordance, so environment must play a role in developing schizophrenia. Looking at biochemical, so postmortems and PET scans have shown that those with schizophrenia had high levels of dopamine, leading to the dopamine hypothesis, which suggests that the synapses that use dopamine as a neurotransmitter are overactive. Antipsychotic drugs can release symptoms by blocking dopamine receptors, but they only work on positive symptoms. Looking at neurological, so neural correlates could explain schizophrenia. So Johnston et al. In 1976 found schizophrenic people have enlarged ventricles, so can link the disorder with a reduction in temporal and frontal lobe volume. However, this is only correlational, so does not necessarily show cause and effect. And an abnormal brain structure may be a symptom rather than a cause. And then lastly, looking at evolution, people diagnosed with schizophrenia share similar characteristics with the shaman of the past. Off the top of my head, I cannot remember what the shaman are, but if you look it up, there will probably be a lot of information. There is a strong genetic link, so there must be some form of evolutionary explanation, but there is little evidence to prove this theory. Obviously, evolution is probably not something they'll likely ask you about. It was only sort of small section in the CGP revision guide. And then looking at the psychological explanation. So first, you've got family dysfunction. So, for example, a colon-dominant schizophrenic mother may cause schizophrenia. Bateson's in 1956 double-blind theory looks at the idea that faulty communication can lead to contradictory messages. So, for example, the mother saying "I love you," but in an angry or disappointed tone. And you've also got expressed emotion, and these expressed emotion environments can contain high levels of hostility and also criticism for the individual. and this expressed emotion correlates with relapse in schizophrenic people. Litz et al. In 1958 found dysfunctions such as emotionally distant parents can lead to schizophrenia, but it ignores biological evidence. Cognitive, so this is dysfunctional thought processing such as delusions, thought interference, language impairment, and memory problems. So Meyer, Lindenberg et al. In 2002 found those with schizophrenia did worse in memory and reasoning tasks, showing reduced activity in the brain associated with the task. Cognitive problems are caused by increased dopamine levels, however. And then social cultural. So this look at the social causation hypothesis, which states people with low social status are more likely to suffer with higher social status than higher social status, and this can be as a result of poverty and discrimination causing high stress levels. And in support of this, Harrison et al. In 2001 found people born into deprived areas were more likely to develop schizophrenia with factors such as poverty, unemployment, and crowding. However, it is only correlational. Then looking at the diathesis-stress model, so the biological approach has been criticised for being a reductionist theory, and as it reduces schizophrenia to its simplest components such as genetics and neurotransmitters. However, the interactionist approach does the opposite. It looks at a combination of biological and psychological factors. People are biologically vulnerable to schizophrenia and are more likely to develop the condition if subjected to certain environmental stress, supported by concordance rates with twin studies as they are not 100%, suggesting a combination of biological and social factors. But I believe I will be speaking more about the interactionist approach at the end on the last slide for this video. Then looking at drug therapies, this is based on the dopamine hypothesis that we spoke about earlier, using antipsychotic drugs to block dopamine receptors. And there are actually two types of antipsychotic drugs, typical and atypical. Typical were developed in the 1950s but treat only positive symptoms with severe side effects including dry mouth, dizziness, and tremors. Typical also only treated positive symptoms using dopamine, and then atypical antipsychotic drugs came along in the 1970s mainly, using both serotonin and dopamine, and this allows it to treat both positive and negative symptoms, but it does still have very harsh side effects. So obviously strengths are effective at reducing positive symptoms and are successful for majority, but they are not very effective for negative symptoms, and it can lead to long-term side effects such as greater risk of diabetes. And then looking at cognitive behaviour therapy and family therapy, so CBT is based on assumptions that patients can be helped by changing faulty cognitions based on Ellis's ABC model, so activating event, exploring beliefs, and recognising consequences. Encouraged to reality test their hallucinations and delusions, pushed to challenge beliefs and question the origin of the voices, encouraged to engage in positive self-talk. Role play and homework are encouraged to help see the consequences of thinking positively. They can gradually see their faults in their thought patterns and begin to change. Chadwick et al. Chadwick et al. In 1996 studied a man with schizophrenia and who stated he could predict what people were going to say. So Chadwick showed him 50 videos pausing at certain intervals. The patient did not predict correctly once, so this is a form of reality testing. And support for this comes from Sensky et al. In 2000. So CBT was effective in those who didn't respond to drug treatment, helping positive and negative symptoms, and were continuing to improve 9 months after treatment's finished. However, it does not address the cause. I've written course as in studying, not cause as in cause. So sorry, I'm aware there's a few spelling mistakes in here. I'm really sorry. I'm just trying to get these videos out sort of as quickly as possible to you. And then family therapy. This reduces conflict and high emotion to form alliances, reduce the burden of care, and encourage realistic goals, and is often used alongside other treatments such as drug therapy. Pilling et al. In 2002 found family therapy reduced the rate of readmission in some patients, but not every family is open to engagement and changing their behaviour, which is one of the more difficult sides of it. Then looking at the token economy, so this is based on opera conditioning, encourages socially desirable behaviours, and so basically the individuals are given tokens to reinforce the behaviours, which can be exchanged for sweets or cigarettes, for example. And then Alon and Azrin in 1968 found that 45 female patients received tokens for good behaviour but were taken away for bizarre behaviour, and then completed a naturalistic observation to assess effectiveness. And these individuals were institutionalised for an average of 16 years and displayed bouts of screaming, incontinence, and aggression. And they've supported this use of token economy as exerted control over behaviour to give patients back a sense of dignity. It does lead to significant improvements in self-care and desirable behaviour, and works best within institutions. However, there is low ecological validity, and there are possible ethical issues as well. And then lastly, looking at the interactionist approach, this is the biopsychosocial approach, and it's a holistic approach, so it emphasises that treatment should be holistic, involving biological, cognitive, and behavioural therapies. Obviously, it makes sense to use a variety of treatments, but it's difficult to know which treatment is actually working and helping to improve the situation, and treatment will also vary depending on symptoms, willingness to try new things, and learn new social skills. I hope that video was helpful for you. It was quite quick, very, very concise, but obviously I'll put my email down below, and I'll try to remember to put the link for the PowerPoint down below in the description. So, and obviously if you have any questions, comment them down below, but you might actually find it easier to contact me if you email me. So, and also if you have any issues accessing the PowerPoint, please email me as well about that, so that I know and I can try and work on it to make sure you can access it. So anyway, I hope you guys enjoyed this video, and good luck with your exam, even as for this year or 2020, 2021, whichever one it is. Good luck. You can do it. I believe in you.